It's now my pleasure to introduce Dr. Ros Sims, who's come all the way from Newcastle, and she's a clinical lecturer in renal medicine there. And she's going to do a double act with Paul Wynyard, who's come from the Institute of Child Health. And Paul is a paediatric nephrologist, and Ros at the moment is still planning, I think, to be an adult nephrologist. And their title is Screening What, Who and Why.
Thank you very much for the kind introduction, and thank you for inviting me to be here today. It's a pleasure to be involved. So I'd like to discuss screening, what this means, who we screen and why. And I'll talk a bit more about adults and what this means for you, and Dr. Wynyard will talk a bit more about what it may mean for your children. So what is screening? It's essentially a method of assessing a healthy or an asymptomatic individual who may be at an increased risk of a condition, and that's NHS defined. Okay. And examples of national screening programmes, which you may all be familiar with, is the breast cancer screening programme, which is offered to women over the age of 50, and also the bowel cancer screening programme, which is now offered to everyone, obviously male and female, over the age of 60. And what screening involves is a test. And the key important features of that must be, it's a screening test, so it must be safe, it must be simple and widely available, and also it must be low cost, because NHS finances are difficult enough as it is. It must be acceptable to the person receiving the test, so it shouldn't be too invasive or obstructive, and it should be fit for purpose. Now, the definition of fit for purpose is a little bit more tricky, because what we mean is that the test will correctly pick up the diagnosis in the majority of people, and there'll be very few people that will be falsely diagnosed or given reassurance at a stage when they shouldn't be. Unfortunately, all screening tests have that sort of challenge, and that's something that we all focus on very carefully. So how do we screen people? Well, following genetic counselling, where if someone else in your family has been diagnosed with the condition, you'll be warned about the risk of you potentially also inheriting this condition. And you, as a family member of someone who has been diagnosed with the condition, would be defined as being at risk. And methods which may be used at different stages, from children to adults, could include blood pressure, so urinalysis, and by doing that we dip your urine and look for any signs of blood or protein, because that may be more suggestive, although it could also happen in a variety of other kidney conditions. We may also check your bloods and see what your kidney function is like, and really the sort of most recognised and widely used screening method at the moment, as Dr. Sanford had mentioned, is ultrasound scanning of the kidneys. So this is an effective screening test because we know it's safe, it's done to pregnant women, it's simple and it's very widely available, and it is, relatively speaking, low cost compared to other methods, and it, generally speaking, is widely acceptable too. And there are diagnostic criteria which Dr. Sanford popped up, but these basically define a cyst count depending what age group you fall into, and it's been recognised or validated from people in the age of 15 all the way up to those over 60. And I guess perhaps importantly, if you're over 40 and you have less than 2 cysts, then there's meant to be a very strong ability to exclude the diagnosis of ADPKD. As I mentioned, unfortunately, with most things in life there are caveats, so it may not be diagnostic, and this is particularly the case in people who are younger. And I'm pleased to say that young is still identified as those less than 40. It may falsely diagnose, as I mentioned, and it may perhaps excludes the diagnosis of ADPKD, but usually at this stage we would then recommend, if there was uncertainty, we would recommend further scans at a later stage or potentially additional tests. And these additional tests may include more detailed scanning, such as a CT scan or an MRI, and if you, as a family member of someone who has known ADPKD and who are willing to consider yourself as a donor for them for a kidney transplant, then often you would undergo slightly more rigorous scanning. It doesn't mean that CT or MRI are better. They use the same diagnostic criteria. They just pick up smaller cysts, and we have to be careful and mindful of thinking about that when we interpret the results. So genetic testing is a diagnostic test. It's not really a screening test that we offer. Genetic testing is a diagnostic test, although we could consider it a screening test if you had a family member had been diagnosed by genetic testing and then you, as a potential kidney donor, were screened for that same change in the gene, because we know the same change tends to run through families. And what genetic testing is it's simply a blood test, and usually they identify the change in the gene in the person who's affected, and then any family members who have not yet been clearly diagnosed, say by ultrasound scanning, you would then consider performing the same blood test and looking for that same change in the family member. The problems with genetic testing are it takes a bit more time because the genes that are involved in PKD are big genes and have got various changes, so it needs careful analysis, and also it's quite expensive. So that's why it's not widely offered and it's not a screening test. So who do we think about offering screening to? Well, as I've already mentioned, it's generally to family members of an individual who's known to have ADPKD, and they may have been diagnosed having presented with symptoms. And it's usually adults, and that's because they can offer informed consent in terms of being advised what the outcome would be of having a positive result, and equally having a negative result, what that may mean for you. And as I mentioned before, slightly more extensive testing would be involved if you are willing to consider yourself as a kidney donor for someone else in your family. And the most important point of that is that to do no harm, in a sense. So if you're willing to offer a kidney, we need to make very, very sure that you are not affected by the condition. So, as we've just mentioned and someone's just asked about, is about intracranial aneurysms. And these are not a common complication for people, but do happen, and they do tend to run in families. So you may be offered screening in terms of having a scan, and the frequency of which we do this is there's no very clear guidelines, although we are becoming tighter, as Dr. Sanford mentioned. But if someone in your family has had an aneurysm, or if you perhaps have a very high-risk occupation, or if you had any particular symptoms that may be suggestive, then you may be offered screening. And again, that may be something that differs locally from region to region. So just coming down to why we offer screening. Well, the benefits are that we, I guess, have earlier management in terms of any complications you may run into. Blood pressure control, we know at the moment, is one of the most important targets that we're focusing on. It can give you some education and awareness in terms of family planning, and some people may feel that's very important to them. It's a very personal decision. It's an exciting time for PKD. In the last 10 years, there's been a lot of trials that are ongoing, and I really think the course of this condition will change very much in the next 10 to 15 years, because I think treatments will become available. I think it will be more than one drug. There's not going to be one amazing drug. It's probably going to be combination therapy like people who have transplants have. But I think it's an exciting time, so you may feel it's not a negative thing to have this diagnosis. And some people may just feel personally curious rather than waiting for something to happen. They may seek to know what's going on. But it's a balancing act. There are potentially some disadvantages, and some people may feel that they would face personal discrimination or discrimination at work or through insurance, and that's something you always have to think about carefully, and that's why you're offered genetic counselling before you go through screening. So I'll probably pass over to Dr. Wynyard.
Fine, so my name is Paul Wynyard. I work at Great Ormond Street and the Institute of Child Health, and I'm a paediatric nephrologist, so I see children with kidney problems. I do a lot of research in the lab, looking at, sorry, is that picking it up for you? Is that all right for you? Looking at animals and cells that have PKD and seeing if we can develop new treatments. And it's very nice of Tess and Fiona and Dick to ask me to talk about this, but of course the problem is I don't know the answer to it. So I hope that you guys are going to inform some of our discussions this afternoon. We've also got a survey to do about this, because I think it's one of the things that it's a bit of a Cinderella story about ADPKD in children. And this is the history of it. So when I trained, they said, oh yeah, ADPKD, it's something that causes kidney failure when you're 40, 50, 60, right? So it's an adult disease. Why do paediatricians need to be interested in it? There's no treatment. So again, why do paediatricians need to be interested? And even if you do a scan, as we've said, if you do a scan when you're 10 and you have no cysts, it doesn't mean you haven't got the disease. It's confusing. So effectively, paediatric nephrologists have said, yes, there might be the odd one where there's a problem. And there's the odd one because some babies will present with cysts and PKD before birth, but most people don't. So effectively, the issue has been, do we bother? Do we actually care about ADPKD in children? That was the sort of attitude maybe 20 years ago. I think it is changing. And I'll just give you my personal practice on this. So I do fetal medicine. So I do counselling effectively of ladies who are pregnant with a child that has a kidney problem. So I do this at UCH, and we get referrals from all over the southeast of England. So usually in that session there'll be lots of different causes. But I did a clinic a few months ago. We saw 10 people in the clinic, and 6 of those ladies had a child with PKD. So I'm thinking, blimey, this is common. And more babies are being diagnosed because of the better scanning. So when I started doing this 20 years ago, it was like looking at old black and white TV. Now it's looking at a super high definition ultrasound. So we can diagnose things now that we couldn't diagnose years ago on ultrasound before birth. Also, more children are being diagnosed because of family scanning. So if you have ADPKD, then either the geneticists or your adult nephrologist may refer your children for scanning. So we're getting other kids diagnosed. And one concern is that there's evidence from the USA, particularly in Denver. They have a fantastic centre in Denver that has 400 children with PKD, and they've been looking at the families with PKD over many years. There's evidence that a small proportion of children with PKD will have high blood pressure. So I thought, along with Mansa, who's one of our research people at the front, stand up, Mansa. Yes. She's going to come to. She's got the survey we want to fill in. That's why I'm getting her to stand up. We thought, why don't we just ask all the paediatric nephrologists? Because if your child has hypertension, the GP should not be managing it, because GPs don't have the right cuffs to measure blood pressure. They don't know what the right scales are for blood pressure in children, because it's different to adults. So if your child has hypertension, you should be being managed by either a paediatrician with interest in hypertension or a paediatric nephrologist in hospital. Okay? So we just surveyed all the paediatric nephrologists. There are 72 of them, and we got a 60% response rate, which is brilliant, except we ask questions like, how often do you see the children? What do you do when you see them? What do you do if there are complications? And it's absolutely apparent that there's not a consistent way of managing children with ADPKD in the country. So I, for example, will see children 6 monthly for the first 2 or 3 years of life, and then yearly after that, with a blood pressure check, a urine check, and the occasional scan every 2 or 3 years. Some places said, we see them every 6 months, which is brilliant, except it's probably a waste of time, don't need to do that. Some places said, I'll see them every 5 years. And some places said, oh, we're not concerned, we just send up the geneticist and let the geneticist look after them. So it's completely different wherever you are in the country. And the other thing which is interesting is nobody's going beyond routine clinical tests, as I've said, measuring blood pressure, dipping the urine. So if you really want to comb down on whether somebody's got hypertension, you need to put a 24-hour tape on somebody. Again, very difficult in children. Imagine trying to do that in a 5-year-old. Are they actually going to stay still long enough? And if you really want to see if there are other issues, for example, you may have heart issues, if you have hypertension, you need to do a scan. Nobody in the country is doing it. I'm not doing it because it costs money, and currently the NHS is not set up to do those scans. So I think there's such a variability. I just think we need to throw it open to the group, and that's what I hope we're going to do in our breakout sessions, which is discuss what's happened to you with your children, discuss what you perhaps want to be done with your children. Is it an issue? I know one of my colleagues will say, actually, at the moment, is it ethical for you as a parent to say, oh, let's scan my child when they're 3? We can't do anything about it. Is it ethical? Why don't we wait till that child's 16, 17, 18, then tell them about the disease and see if they want to have those scans done? So that's the sort of issues we want to discuss. What do you guys feel about that? Okay, so in order to answer that, we're going to have our breakout sessions, and we've got a parent survey. I should actually say it's a bit ageist. I just realised it's a bit ageist because we called it a parent survey, but there's some young people here, and there's some older people in here, so it's actually should be called a family survey. So I apologise for I've got the wrong title on that. Okay, but I think it's one of these things that we're in equipoise at the moment. Are we doing the right thing by our children by effectively letting everybody have their own practice if you're in Norwich, if you're in Nottingham, if you're in Newcastle, or should we, as a group of interested ADPKD affected families, doctors, be saying, actually, to be absolutely fair to everybody across the country, this is the minimum standard we expect for somebody with ADPKD to be looked after. So I'm interested to know your opinions about that. Thank you.
Good. I suspect that there will be lots of questions this minute, and you also have 2 opportunities to participate in a breakout group about the management of children, or at-risk children, as it might be better to call them, since they are only at 50% risk of inheriting the condition. I should also add to what Ros said, that if you are one of the Cambridge PKD patients, we in fact offer genetic screening to everybody. In the beginning, we could only do PKD2 testing, but we're now proceeding for those who are PKD2 negative to be able to test PKD1, and the results of that will be trickling out in good time. What we've done is to select first those who've got families where there are others at risk in the family for that extended screening. And of course, it needs some genetic counselling and a discussion of what it means before you go through with that. There is supposed to be a moratorium on the insurance question. I know some insurance companies aren't as good as others, but technically speaking, you shouldn't, I think, have to declare anything.
So that's a very interesting point, actually. But where do you get the money for doing that? Because actually, we wouldn't have the money to do that sort of screening. So it's unfair, isn't it? If you live in Cambridge, you're obviously getting a really good service. If you live in Newcastle or London, you're not getting that service. That's just not fair.
We're not sure how long the good days are going to last for, but our regional service has allowed us to do this up till now. Okay, questions from the floor for both these two speakers.
A rather vague question about the difficulties of genetic testing for PKD. I asked this because I had my genes analysed by the American company 23andMe, expecting PKD to come up with a red flag, and it didn't find it at all. Any thoughts on that?
So there are a number of potential difficulties associated with companies like 23andMe. One of those is that their ability to diagnose every genetic condition is not uniform across your 46 chromosomes. And part of the reason in PKD that there are problems is that the genes are very, very large and at least partly duplicated. And what we've done in Cambridge is to develop special means of avoiding those problems. And our hit rate for finding mutations is extremely high. 23andMe will never be able to keep up with that. It will also potentially tell you about things that actually you might not have wanted to know about. So I personally feel very wary about companies like that at the moment. I think in the future, when the technology improves, it'll be fantastically valuable.
I just want to know about, you said about the brain aneurysm. But I had my father and my grandgrandmother dying with brain aneurysm, and my father with abdominal aneurysm, and had a transplant and everything. But I just want to know, as myself as a patient or anybody, how often do we need to be screened with a scan?
I don't think there's a clear answer. There's recently been a few publications which have recommended varying amounts depending on who in the family has been affected before. It also comes down to the size of anything that's found. So if you have a negative scan but have a positive family history, if you've been scanned before and are told you're clear, then some centres might advise you are rescanned again in 3 years. Some might say 5 years. So it does seem to be quite variable depending whereabouts you are in the country. And there doesn't appear to be national guidance on this. But to say there is also, if anything is found as a positive scan, it also depends on the size of it and then how frequently you were rescanned to see if it was changing or if it was staying stable, because clearly to undergo surgery for something that may not cause you any problems is also something to consider. I don't know, Dr. Sanford, if you want to add anything to that.
So in Cambridge, if you have a positive family history of an aneurysm, we will request screening, and if it's clear, we'll ask for it to be done again after 5 years. If something is found, we will ask the neurosurgeons to advise us on how best you should be managed, because actually we're physicians. And it is true that you can't always sort of jump in, and you may wish to watch, and how they watch is probably more accurate as to how we would do it. Does that answer your question?
If you have a cerebral aneurysm, what's the risk of another one appearing?
So you mean you've had one and it has burst already, or?
I've had one cold case coiled.
Right, okay.
And that was caused by me pressuring consultants and registrars to have a scan.
Right.
Because my grandmother died of brain hemorrhage when my father was only 4, and then it was just classed as a brain hemorrhage, full stop.
Okay. I have to confess I don't have the knowledge, I'm sorry to say that, but I don't have the knowledge to answer that question. I'm sure you would be offered scans every so many years afterwards as follow-up, but the chances of another one occurring, I have to confess, I'm sorry, I don't know the answer to that.
So the answer is small but significant, and numbers are difficult to get hold of on that. I hope you have been offered a follow-up screen sometime in the future after that. Okay. We can discuss that afterwards. Good. Other questions on this? Yes?
So probably this is a question for Paul, probably. So if an infant is, let's say, if you detect cystis in an infant, does it mean that the infants will develop the ADPKD earlier in his life, if it's already detected before the birth?
It's interesting that you think logically that should be the case, but when they've done big studies, actually it doesn't seem to be the case. So it seems that you can have a few cysts and still not have any problems through childhood. The Denver studies of several hundred children, for example, show that of those, 2 children reached end stage by the age of 16. So the chance of actually, it's very, very rare. There are some, but this is for normal ADPKD. There are some very, very aggressive forms that present antenatally. And in that situation, antenatally, with a reduced amount of urine coming out the kidneys because the kidneys are not working properly, then they do have a problem. But the ones that go beyond that, which are just the normal ADPKD, then your chances of having early kidney failure are not much increased.
This is to Paul as well. You mentioned that with regards to children and blood pressure, that the GPs can't monitor their blood pressure. So how would you get your child's blood pressure checked if you wanted to do that?
I think you need to go to a specialist centre where they're used to doing it. So the key with blood pressure is you need to have a cuff which is 2/3 of the size of your upper arm. So if you imagine the size of an adult cuff, it's about 12 centimetres. So a child will be 7 or 8 before you actually get 12 centimetres up there you can measure it with. So they just don't have the cuffs to do it. And actually measuring a blood pressure in a screaming child, because they don't like having blood pressures measured, is very difficult. Yeah. Well, I really think you've got to be you've got to be an adolescent to fit an adult cuff properly. And it's interesting because one of the nephrologists in Manchester, for example, just got a student to look at 10 GP surgeries around their centre, and 3 of them had a cuff which was the right size to measure children 7, 8 or whatever. The other 7 didn't, and in fact, of the 3, one of those didn't have a working machine that we could connect to. So you're talking of about 20% of GPs that probably have got something. They never measure blood pressure in children, and I wouldn't believe it. You're recording this, and I'm being very rude about GPs. If you don't do things very often, then how can you expect to be accurate? That's what I mean. It's not denigrating GPs. I couldn't do neurosurgery anymore because it's a long time since I learned how to do that. Yeah. Well, this is the difficult thing. That actually, if you want your children looked after and have a blood pressure measured properly, you do need to get them referred. Yes.
Is there an age limit to children? My 17-year-old has got the kidney. I've got the liver and the kidney.
Yeah.
I'm trying to find out whether, I don't even know at this point whether he actually is going to have the liver to the same proportion I have. He's having his blood pressure taken, but I presume that at 17.
Oh, 17. It'll be puberty is the key. You gain 8 to 10 inches post puberty. So and you just get bigger. So.
And there's nothing, and the only way I can tell if he's going to get it the same, because my mother had it, but she had it in her kidneys and not her liver. I've got it in my liver and my kidneys. I have no idea, I presume,
So it's actually,
whether he's going to have it in both organs or just,
I'm going to have to refer to the adults for that, because polycystic liver disease is very rare in children. I've seen it a couple of times, but it's very, very rare. Yeah.
And obviously the balance between the cystic kidneys and cystic liver is different in different people, and some people never develop liver cysts, and some people have very few kidney cysts, but they still come under the same sort of mutational umbrella. I must say, and I'm going to differ from Paul here, in our adult practice, we do get asked by parents, and to my mind, if it's not going to affect the course of the young childhood, and you did say it was a small percentage that really develop problems, then it's quite important for a child to be able to participate in the discussion. And therefore, when they get to puberty, is the time that they can understand what blood pressure measurement is all about. That, to my mind, is a better time to start measuring blood pressure. But I'm one of a small cohort of people who think that, and there are people who think you should do everyone, and there are people who think you should do no one. So,
but the problem with that approach is you will miss people who are 5, 6, 7, 8. We have children who are 8 with blood pressure issues, so you will miss them. But if it's a tiny proportion, then there's a question about resources and whether you should put resources into that, which is a health economics debate.
Can I just say, the only other thing I found is that when my son
So a child shouldn't need a blood test unless the diagnosis has been confirmed. And if those tests are normal, it shouldn't need to be done for at least a couple of years or a year.
The trouble is when they come to clinic, we do the blood test, but actually the blood test's not as useful as measuring the blood pressure and dipping the urine. Because that diagram that Dick showed with all the cysts and the kidney function, you know, there's a nice flat line along the top which relates to the blood test. The blood test will not get abnormal until that line starts curving down over. So.
A minor point about liver cysts. They're very much more common in women. It's hormonal partly, very much rarer in men. It's not a golden rule, but it's a general rule, much more common in women. So boys don't tend to have